So, welcome everyone to July DUR board meeting. A few reminders for our meeting today. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute the device via Google Meet. For the DUR board member, please reserve the question until the end of the presentations or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a COI must be on file. Please send an email to medicaidpharmacy@utah.gov. Attendees that are not member of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed. Please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And with that, I leave it to Dr. Kemen.
Thank you. Good morning. Looks like it's going to be another hot one today, huh? We might even have a hot meeting. Who knows? Call this meeting to order. Thank you, everybody, for taking the time to get up early and be here. In terms of housekeeping, Noon, do we have anything?
Yes, we do have several housekeeping items. Sapide, if you want to give an update.
Yeah, why don't you do the housekeeping and then, well, why don't we do this? Everybody should have received a copy of the board minute or the minutes from the last meeting. Hopefully everybody's had a chance to review them, and I would look to see if there's any questions, changes, or a motion to approve. Okay, here are no questions. I would move to approve.
Second.
Thanks, Dr. Keddington. We have a motion and a second. All those in favor say aye. Aye.
Aye.
Any opposed? Hearing no opposition, the meetings from the previous meeting are passed. Noon, we'll turn it over to you for the housekeeping.
Thank you. Sapide, would you like to go first?
Yes, good morning, everyone. Can you hear me well?
Yes.
Okay, awesome. There are two housekeeping and update I would like to share with you. One is, of course, regarding the Change Health outage. There were a couple updates happened since our last meeting in June 13th. After the cyber attack in February 21st, on Wednesday, June 19th, all historical drug file updated in our system and point of sale and drug file they updated. That should have happened now weekly during the that supposed to happen during the outage weekly. It didn't happen, but now moving forward, we are loading that as regular basis. So that was one update that happened. The second update, just recently, we are working on the PA authorization that we were waiving it, and we are still waiving, but it's work in progress. But on June 28th, we start having some kind of soft messaging in the point of sales. So let our pharmacy providers and also members know that due to the Change Health cyber attack since 21st, the PA requirement for some medications was currently turned off, and we are working on bringing the PA authorization back. More to come. We don't know our exact date on that. Those are the current update with the Change Health. One really good news on July 2nd, we had approval from CMS for J1115 justice waiver. So we received that CMS approval on that, which will opens up great opportunities for Medicaid members to experience a better level of care and smooth transitions as they move from a carceral setting back to the community. Those are the two main updates that I have. Thank you.
Additional updates for housekeeping item is fee-for-service has submitted one of the CMS DUR survey annually for both fee-for-service and the ACO. And that's all the update we have today, Eric.
Great, thank you. Brian, any update from P&T?
I don't have any updates on P&T today.
Great. With that, we will turn things over to the University of Utah to talk about stimulants for ADHD and sedative hypnotics. And Monet is on camera, so I'm guessing this is your show.
Yes, it is. Thank you so much. Okay. Good morning, everyone. Today, I will be reviewing the evidence of concomitant use of stimulants for attention deficit hyperactivity disorder, abbreviated ADHD, and sedative hypnotics, focusing on safety concerns. Additionally, I will review utilization data in the fee-for-service population regarding the use of ADHD stimulants and sedative hypnotics. ADHD is characterized by symptoms of hyperactivity, inattention, and/or impulsiveness. Insomnia is considered difficulty initiating and/or maintaining sleep or experiencing poor sleep quality despite conducive sleep conditions. Sleep disturbances are common in patients with ADHD, with more than 50% of pediatric and adult patients with ADHD suffering from insomnia. The impact of ADHD stimulants on sleep varies significantly between individuals, with some patients experiencing improved sleep when their ADHD symptoms are adequately treated with stimulants. In other words, suboptimal treatment of ADHD may contribute to insomnia in some patients. However, some patients may experience exacerbated sleep issues related to the stimulant, potentially causing delays in falling asleep or difficulties maintaining sleep. Inadequate sleep can negatively affect quality of life, academic or work performance, and cognition, as well as exacerbate symptoms of ADHD. The administration timing of ADHD stimulants and sedative hypnotics is important to consider, as these agents are not taken at the same time of day, as shown on the next couple of slides. ADHD stimulants are either short-acting or long-acting, amphetamine or methylphenidate based, and have an effect duration typically ranging from 3 to 6 hours for short-acting preparations or from 8 to 16 hours for long-acting preparations. Usually, long-acting agents are taken once a day in the morning, and short-acting agents are taken 1 to 3 times daily. Related to the time of administration and duration of action, and depending on the patient, the stimulant effect may or may not wear off by bedtime. All ADHD stimulants are Schedule II controlled substances considered to have high abuse potential that can possibly lead to physical or psychological dependence. Sedative hypnotics are classified into 5 drug classes, including benzodiazepines, non-benzodiazepine, benzodiazepine receptor agonists or Z drugs, orexin receptor antagonists, melatonin receptor agonists, and histamine receptor antagonists. Related to the onset of action, most sedative hypnotics are indicated for sleep onset insomnia and/or sleep maintenance insomnia. Several of the rapid, short-acting benzodiazepine hypnotics and low-dose zolpidem sublingual tablets are approved for middle-of-the-night awakening with trouble falling back to sleep. Tazomiltian is indicated for rare non-insomnia sleep disorders. A certain agent may be prescribed to a patient based on its approval for the specific type of insomnia disorder. For example, low-dose doxepin is not considered effective for sleep onset insomnia. Sedative hypnotics approved for insomnia are typically taken close to bedtime, except for doxepin, rameltian, and tazomiltian, which are non-controlled. Sedative hypnotics are classified as Schedule IV controlled substances. We reviewed 3 ADHD guidelines, 1 each from the American Academy of Pediatrics, or AAP, the Canadian ADHD Resource Alliance, or CADRA, and the United Kingdom's National Institute for Health and Care Excellence, or NICE, for recommendations on the management of sleep problems in patients with ADHD. Additionally, we reviewed an accompanying AAP treatment algorithm and a 2019 European consensus statement. None of these guidances address the use of prescription pharmacologic agents approved for insomnia as a treatment option in patients with ADHD and insomnia, potentially because this topic was beyond their intended scope. ADHD clinical practice guidelines recognize the need for treatment of frequently co-occurring insomnia and encourage sleep hygiene and/or ADHD stimulant adjustment, such as changing the dose, administration timing, or formulation as first-line treatment strategies. If the patient continues to experience insomnia, melatonin may be an option, particularly in children, as there is some evidence supporting its use in children, and it has a favorable side effect profile. In adults with ADHD, there is limited anecdotal evidence of benefit with melatonin. Yet in the US, as an over-the-counter supplement, melatonin is not regulated as strictly as prescription products, which presents potential quality and/or purity concerns. Moreover, U.S. guidelines for the treatment of chronic insomnia in the general adult population do not recommend over-the-counter melatonin because there is insufficient evidence. Expert guidance for pediatrics tends to suggest adding pharmacological sedative hypnotics as a later line option for refractory cases in children with ADHD and insomnia, and presumably in adults. The decision to use these medications, particularly in children, should be carefully evaluated between the provider, inpatient, and/or caregiver, typically after exhausting all other options, as there is limited evidence for use. According to identified reviews, studies evaluating the safety of sedative hypnotics in patients with ADHD is limited. From these reviews, we found 3 placebo-controlled randomized controlled trials, or RCTs, 1 small crossover trial evaluating the efficacy and safety of Ramelteon in adults with ADHD-related insomnia, and 2 trials evaluating the efficacy and safety of either azopiclone or zolpidem in children and adolescents with ADHD-related insomnia. The included population of adults with ADHD in the Ramelteon trial had a mix of sleep disorders, including some with primary insomnia and others with delayed sleep phase circadian rhythm sleep disorder, or CRSD, which is a distinct sleep disorder from insomnia according to the newer Diagnostic and Statistical Manual of Mental Disorders 5th edition criteria. The proportion of included participants taking ADHD stimulants in the total population was not provided, but a subgroup analysis of participants with actigraphy outcome data noted that 54% of participants were on a routine ADHD stimulant morning regimen. Both pediatric trials enrolled children and adolescents with ADHD and complaints of insomnia and a latency to persistent sleep of greater than 30 minutes. High proportions of enrolled patients were receiving ADHD stimulants in these 2 trials. Notably, none of these studies compared outcomes by subgroup of ADHD pharmacologic treatment status, so the safety profile of these agents, specifically among patients who received ADHD stimulants, is unclear. The safety profile of Ramelteon in adults with ADHD was similar to the general adult population. Adverse events, or AEs, were mild, with drowsiness being the most frequently reported AE. In the zolpidem RCT, the most common AEs occurring more frequently with zolpidem than placebo were dizziness, headache, and hallucination. Although most AEs were mild to moderate in severity, 10 participants in the zolpidem arm discontinued treatment due to AEs, most often hallucinations. In the azopiclone RCT, the most common AEs among azopidem-treated participants were headache, dizziness, and altered sense of taste, which occurred more frequently in patients in the high-dose group relative to other treatment groups. The severity of most AEs were mild to moderate. Reported AEs during the 12-month follow-up study for azopiclone were consistent with the double-blind period of the RCT. After searching the FDA's website for safety communications from 2010 to present, we did not identify any communications or labeled warnings regarding any particular safety issues with respect to concomitant use of ADHD stimulants with insomnia pharmacotherapies. Nonetheless, we compiled the risk related to use in general of these drug classes, regardless of concomitant use. ADHD stimulants and benzodiazepines have a black box warning for the risk of abuse, misuse, and addiction. Because physical dependence develops over time while on benzodiazepines, serious, potentially life-threatening withdrawal reactions can result from abrupt discontinuation or a rapid dose reduction. There is also a black box warning regarding the respiratory depressant risk of combining benzodiazepines with opioids. For Z drugs, there is a black box warning regarding their potential to induce complex sleep behaviors. Drug interaction software by LexiDrug returned only one interaction between amphetamine and methylphenidate-containing stimulants in any of the reviewed sedative hypnotics, in this case with doxepin. Doxepin may potentiate amphetamine-associated cardiovascular risks, and concurrent use of doxepin with methylphenidate could result in serotonin syndrome. Notably, these potential interactions might be based upon use of higher dose doxepin when used as an antidepressant, rather than low dose doxepin used as a sedative hypnotic. We identified 3,305 Utah Medicaid fee-for-service or FFS patients with a diagnosis of ADHD and an outpatient pharmacy claim for an ADHD stimulant during the observation period from May 2023 through April 2024. Of these 3,305 patients, only about 3% filled a sedative hypnotic within 30 days after an ADHD stimulant fill, which I'll refer to as the concomitant cohort. The most common sedative hypnotic drug class filled was Z drugs. Patients in the concomitant cohort were nearly all adults. Based on patient count, the most common sedative hypnotic filled was zolpidem of any formulation, followed by a zopiclone. Except for temazepam, there were no fills for other hypnotic benzodiazepines, nor orexin receptor antagonists, low-dose doxepin, or tazomiltione. Overall, there is a paucity of research regarding the treatment of insomnia in adults with ADHD, thereby making it difficult to conclude there to be any additional risk in this subpopulation beyond those that apply to the general population. Currently, Utah Medicaid does not require a prior authorization and has no restrictions regarding concomitant use of an amphetamine or methylphenidate-containing stimulant with a sedative hypnotic. At this time, we do not view there to be a strong foundation for having stricter restrictions in the subpopulation with ADHD versus the general population. However, it may be reasonable to consider performing a retrospective drug utilization review and communication to providers of patients who are continuously filling prescriptions for both an ADHD stimulant and a sedative hypnotic, particularly if prescriptions are from different providers. The intention of the intervention is to garner attention to the provider of potential modifications to therapy if appropriate and not previously tried. For the treatment of insomnia in patients with ADHD, providers should be encouraged to try first-line behavioral-based interventions if available to the patient, and or try adjusting the ADHD stimulant dosage, administration timing, or formulation before trying pharmacological options for residual insomnia. However, we acknowledge that the provider may have already tried or considered such first-line approaches and has moved on to later-line approaches, which could apply to this 3% of patients with ADHD we identified using an insomnia medication. Regardless of concomitant use, providers could be encouraged to monitor for potential signs or symptoms of abuse, misuse, or addiction in patients treated with ADHD stimulants, benzodiazepines, Z drugs, or orexin receptor antagonists, as these are all controlled substances. This concludes the presentation. Thank you for your time and attention, and please let me know if you have any questions.
All right. Any questions from the group? Okay, hearing no questions.
I just have one, and it's more curiosity. On the data set of all the fills of the 3,000 people, do we have a breakdown of if those are adults or children, like the actual first cohort before the usage? I'm just curious if, because it could skew, most of our prescriptions are probably in children, which we're not going to use a lot of these sedative hypnotics in, because there's just not a lot of data. So
Yeah, and that's a good point. A lot of the insomnia medications, in fact, most of them are not approved for use in children. None of them are. So yeah, when we saw this data breakdown, it's good to see that majority of the patients that had ADHD stimulant filled and then filled a sedative hypnotic within 30 days, because we were trying to catch those who were most likely concomitantly using them together. Were mostly in adults. This 3,305 cohort were only those patients with an ADHD diagnosis who filled an ADHD stimulant within the last 12 months. So we didn't do an additional breakdown on that, the really large cohort, because they hadn't filled a sedative hypnotic yet.
and then going off that, do we think that because we just looked at ADHD that we're missing other indications for stimulants, because it could be like narcolepsy or something else where they might also, have a sedative hypnotic or some other medicine to help with sleep and then help with daytime wakeness. So I'm just curious if we think we're missing some in that regard.
This report's focused solely on ADHD, so that's why we were trying to capture those patients with an ADHD diagnosis specifically. But yeah, that's correct. There are some of the ADHD stimulants are also approved for other indications, such as narcolepsy.
All right, thank you. Noon, do we need to take any action? I think as we look at kind of the data here, probably pretty low impact, and probably not something to create another process around. At least that's my personal opinion. Others may feel differently, but just wanted to double check with you.
Thank you for that. If the board don't feel like there is a need for it, maybe there could be a motion for no action needed to be taken at this point. Or no motion is needed either way.
Right. Dr. Weinstein.
Thank you. I was just thinking to move, we accept the report as written with thanks to the University of Utah, and note no action is needed at this time.
We have a second.
I'll second that motion.
Thank you, Dr. Siegfried. All right, we have a motion and a second for a big thank you for Monet and her report. And at this point, no action is needed. All in favor? Aye.
Aye.
Any opposed? All right. We haven't talked enough about GLP-1 inhibitors in the last year, and so Stephanie is going to update us on Wegovy.
Thank you, Eric. And yeah, I'm almost sick of talking about GLP-1s over the last few years, honestly.
Almost. So you had to come back for one more day.
I guess so.
All right.
All right. And so I do want to clarify that this prior auth is just for the new indication for Wegovy. It's indicated in combination with a reduced calorie diet and increased physical activity to reduce the risk of major adverse cardiovascular events, or MACE, in adults with established cardiovascular disease and either obesity or overweight. So we'll only be talking about that indication right now. It's the only one we can currently cover. So first we have the age criterion. If the patient is 18 years of age or older, for the MACE indication, it is only indicated for adults. The next is the patient have a body mass index of greater than 27. This is for the obesity and overweight part of the indication. Our next criterion requires that they have a past medical history of one of the following conditions: myocardial infarction, stroke, or symptomatic peripheral arterial disease, since these are the conditions that are usually treated to prevent secondary occurrence of major adverse cardiac events. These are also the patients who are included in this phase 3 clinical trials that helped the medication receive its indication from the FDA. The next is just to ensure that the patient is getting appropriate therapy besides just Wegovy, appropriate pharmacotherapy to help prevent MACE as well. So, for example, taking a statin at maximally tolerated dose, optimizing medications to ensure that patients have controlled hypertension, taking a beta blocker if they have a history of MI, or taking an anticoagulant or antiplatelet medication if they have a history of coronary artery disease or other high-risk diagnoses. Those, again, are just examples. It's something we will examine as we review the prior authorization request to make sure they're on guideline recommended therapy for that. The next criterion is making sure the provider attests the patient does not have a diagnosis of type 1 or type 2 diabetes. The reason for that is because the current GLP-1s that exist that are indicated for diabetes, I believe all of them except for Bydureon have indications and have data to show that they help prevent MACE as well, secondary occurrence of MACE. The next is, will the patient continue on an appropriate calorie-restricted diet supervised by a registered dietitian and a medically appropriate exercise program? This is to cover the part of the indication that requires a reduced calorie diet and exercise. Also, again, to make sure that they're already taking appropriate measures to help reduce occurrence of MACE. And the final, this is also part of the package insert. Will the patient be taking another concurrent glucagon like peptide 1 or GLP-1 receptor agonist? That's because therapy with more than one GLP-1 agonist is not recommended. For reauthorization criteria, this is asked by upper leadership to be particularly robust, just because I think we're all aware of the potential for fraud, waste, and abuse for these drugs, unfortunately. So our first criterion is that the patient still has a BMI of greater than or equal to 27 per the indication, FDA indication. Is the patient able to tolerate the maximum maintenance dose of Wegovy, since that's the recommended dose that they should be on? Has the patient experienced an initial weight loss of greater than or equal to 5% from their baseline body weight after 20 weeks and been able to maintain that weight loss? That is also recommended in the package insert for the proportion of weight and also the number of weeks that we should see those outcomes in. The next is that they're still receiving the guideline recommended measures for secondary prevention of a major adverse cardiac event, and does the patient continue on an appropriate calorie restricted diet and medically appropriate exercise program. So just continuing those from the initial criteria, since that is recommended for the patient to continue regardless of pharmacotherapy with Wegovy. And then below, we just have the boxed warnings in the notes. What questions do you all have or comments?
I thought it might be helpful just to maybe copy baseline weight and put that under number 2 for criteria for approval, since you are using that to calculate the BMI.
Okay.
So that so you already have that there.
Yes, I agree with that. Does anyone have any objection to that, I guess?
Can I'm not sure if this is the appropriate time to talk, but I'm Juliana Simonetti. I'm the obesity medicine specialist here at the U. I know I had asked for a few minutes to talk. One question I have is, and something that we have been seeing in clinic as an issue is the history of MI. So an example, I had a patient the other day that had a cabbage with like 3 or 4 vessel disease. And because he didn't officially, they caught it, right? Like they did the procedure before he actually had an MI, but obviously he had symptoms and was hospitalized and had cardiac cath, and then that led to the cabbage. He didn't qualify for Wegovy, but certainly was a patient that would had benefited from this medication. So I know that MI is what they use in the studies, but the data is very clear in the prevention, like the CAD would be more of an appropriate coverage for patients, because I do see quite a few patients like that had, that have very clear, documented diagnosis of CAD, and I can get them covered for Wegovy because they haven't officially had MI.
Thanks, Dr. Simonetti. Typically what we do is we give you 3 minutes.
Okay.
After we've kind of reviewed the criteria.
Oh,
but
sorry. Yeah,
I appreciate your input because I think it's a good question. And we as a committee can talk about that for a second here. And then as soon as we get done kind of having our conversation,
Okay.
we'll turn it over and let you have 3 minutes. And
Okay. Yeah.
then we have one other individual. So perfect.
Okay.
Thank you. All right. Guys, any thoughts about that? The patient having a history of myocardial infarction versus CAD? Dr. Smith?
Yeah, so it might be helpful to use what the SELECT study uses, buried in the appendix of the New England Journal of Medicine study, is their definition of acute myocardial infarction. So they talk about evidence of myocardial necrosis, either changes in cardiac biomarkers or post-mortem pathological findings, and supporting information derived from the clinical presentation, electrocardiographic changes, or the results of myocardial or coronary artery imaging. I don't know if that's helpful. I don't know how to drill that down to something for the prior auth criteria, but maybe that could sort of get to the intent.
So Stephanie, we can come up with all of this stuff. You're left to kind of operationalize it.
Right.
What are your thoughts?
Again, we can come up with the verbiage specifically for it, but I think something kind of like Dr. Smith mentioned, which thank you for that recommendation, say patients who have a past medical history of myocardial infarction or coronary artery disease, and kind of like you mentioned, try to find a way to be a little more specific to the patients who, again, were at risk for MI and were lucky enough to not experience it. Intervention.
Right. I think that's good. Dr. Weinstein, you had your hand up.
Thank you. I'm understanding this is not indicated for everybody with coronary artery disease, but those that would be at a certain risk, and if they've had an intervention that's averted that event, that's what we're aiming for, prevention. But I'm not sure how to characterize further at what level or what other clinical features that would go with the coronary artery disease. And so hopefully we can, as you say, make that more detailed, and our guest speaker may have further thoughts about that, but I think you've got a reference, and that's what we would try to do. If we just put coronary artery disease, I think we'd be in trouble.
I would,
Yeah, I agree.
all right. Any other thoughts? All right. Thank you, Catherine, for the reference there. Appreciate that. We do have public comment. So Logan Poole from Novo Nordisk, if you're on, we'll turn some time over to you. You've got 3 minutes, and typically Brian loves to time people. So let Brian run the timer.
Awesome. Can you guys hear me?
Yes, we can.
Okay. Good morning. Thank you so much. My name is Logan Poole, and I'm a pharmacist and represent the Novo Nordisk Medical Affairs team. I want to thank you guys for opening up the conversation around cardiovascular residual risk reduction and really add comments regarding the use of anti-obesity medications in Utah for patients with cardiovascular disease. I would like to request that the committee endorse coverage of semaglutide injection 2.4 milligram brand name Wegovy for the treatment of patients with obesity or overweight and cardiovascular disease. As you guys have been mentioning, Wegovy label was granted by the FDA an update on March 8th of 2024. And just as a quick reminder of the efficacy and safety of Wegovy, it was originally studied in a multinational, multi-step program leading to the FDA approval in 2021, and it expanded to pediatric patients 12 and older in 2022, and with the most recent update in 2024, where Wegovy became the first and only weight management medication to be approved in combination with reduced calorie diet and increased physical activity to reduce the risk of major adverse cardiovascular events, including cardiovascular death, non-fatal MI, and non-fatal stroke, in adults with cardiovascular disease and overweight or obesity. The cardiovascular indication granted as a result of the SELECT trial was a multinational, multi-center, placebo-controlled double-blind design that randomly assigned over 17,600 participants to receive Wegovy or placebo. This trial was really designed to examine whether once-weekly semaglutide, 2.4 milligrams, lowers the incidence of MACE versus placebo, both added to cardiovascular standards of care in participants with established cardiovascular disease and without type 2 diabetes. Patients had an underlying 82% with coronary heart disease, 82% with hypertension, and 24% with heart failure. And in SELECT, Wegovy significantly reduced the relative risk of major adverse cardiovascular events by 20% when compared to placebo when added on top of the standard of care regimen. There was a reduced risk of cardiovascular death with a hazard ratio of 0.85, composite heart failure outcome with a hazard ratio of 0.82, and all-cause death with a hazard ratio of 0.81, and Wegovy arm versus placebo. The exact mechanism of action for the cardiovascular risk reduction has not been established. The most common side effects of Wegovy are GI in nature and include nausea, diarrhea, vomiting, constipation, among other effects listed in the package insert. No new safety signals were detected in this clinical trial that lasted a little less than 5 years. I'm respectfully asking that Wegovy become a preferred GLP-1 receptor agonist to the Medicaid PDL to expand treatment options available.
All right. Thank you. And does anyone from the committee have any questions for Logan? All right. Seeing none, Stephanie, can I just confirm with you, this can be covered for the cardiovascular indications, but not for the obesity indications. Am I correct?
Correct. As of now, we can't cover for weight loss.
Okay. All right, Dr. Simonetti, thank you for your earlier comment, and we'll give you 3 minutes, and appreciate you taking the time this morning to be with us. So thank you.
Yeah, thank you so much for giving me the time. And I probably won't use all the 3 minutes since I already used my time. So anyway, I'm Juliana Simonetti. I am an obesity medicine specialist and the director here of the Comprehensive Weight Management Program here at the U. The reason why I'm here this morning is just I see a lot of patients with obesity and obesity-related metabolic complications, including patients with CAD and history of MI, really, really complex and patients, in particular those that have Medicaid and Medicare. One point that I brought was the MI. So I think having documented history of CAD, and I think you can certainly, or occlusion in whatever way you want to do that, either history of cardiac cath or, stents or cabbage. I think those would be really helpful. The other 2 points, just from what you brought up today, is that I know that for the trials, they use medical exercise. And in our clinic, we do have registered dietitians and exercise physiologists. However, many of our patients have very limited mobility. Some of them, they're that sick, have very limited mobility. So you do have to be careful in what requirements you put in for what's considered exercise, right? I have many of my patients that do band, sitting, chair exercise. And how do you really get to that? I think it gets a little more complicated. I think seeing a registered dietitian, and as long as you cover those services, I think that can certainly be very, very helpful. My other point is that with no history of type 1 or type 2, we do know that with Medicaid right now, like Ozempic and sometimes, tirzepatide are harder to cover. So I know that might be an issue too. And many of our patients with type 1 and type 2 also have history of MI and, more cardiovascular complications. So I'll stop here. And those are just the points that I wanted to bring up from the review.
Great. No, thank you very much. Does anybody on the committee have any questions for Dr. Simonetti while we've got her? All right. We usually give them about 8 seconds, make sure they're still awake. Thank you very much, Dr. Simonetti. So I think we've proposed a couple changes here to the criteria. Does the committee have any other thoughts or comments? Hearing none, do we have a motion?
Can you scroll down to the part that refers to diet and exercise? Thanks.
Sorry, I was on mute. Number 6.
Okay.
And I appreciate your comment too, Dr. Simonetti, because yeah, I think a lot of people have something in mind when they think of what exercise is required. And a lot of people do have limited mobility and much more different options than some people might consider to be exercise.
I guess the question is, does medically appropriate cover in people's minds what Dr. Simonetti means by that?
Yeah, I think it does, because that would mean it's at the direction of the physician. Okay. Any other thoughts from the committee? All right. Somebody throw me a recommendation.
Move to approve.
All right. We have a motion to approve. Do we have a second?
Second.
Thank you, Dr. Weinstein. All in favor?
Aye.
Any opposed? All right, Stephanie, you got that one. Let's talk about drugs to promote fertility.
1 down, 3 to go. Don't worry, these will be a lot quicker. Sorry, my little sidekick keeps trying to get in on the meeting. So I just want to give some brief background on the medications to promote fertility. So effective May 1st, 2024, drugs to promote fertility are covered for some members. This is a result of 2 CMS approved 1115 waivers allowing Medicaid to cover certain fertility preservation or in vitro fertilization procedures and medications for certain members. Generally, they are members and their partner who are a carrier for or have been diagnosed with certain genetic conditions. And then the other is members who have been diagnosed with a form of cancer that requires treatment that may cause a substantial risk of sterility or iatrogenic infertility, including surgery, radiation, or chemotherapy. There are more specifics on who is eligible, and those are actually copy-pasted criteria in the next 3 PAs I will show, so I'll talk more about that. However, for more specifics, if you refer to the All Providers General Information Section 1 manual, it will include more information on those specific policies. I will mention that for the medical side for these procedures, those are carved out. For the drugs, we weren't able to carve them out because not all of them are used solely for to promote fertility. They have other indications as well. All right, let me switch. Okay, so this first one are for cetrorelix, pholotropin alpha, pholotropin beta, and ganirelix acetate. So the first criterion is that the patient is 18 to 35 years of age. This is specifically for the patients receiving in vitro fertilization for if they are genetic carriers of specific diagnoses. So the diagnoses are cystic fibrosis, spinal muscular atrophy, Morquio syndrome, myotonic dystrophy, and sickle cell anemia. And the third requirement is that the patient intends to get pregnant with a partner who is also diagnosed by a physician as having one of these traits associated with the same qualifying condition that they have. The next are criteria for patients receiving therapy as part of fertility preservation due to different treatments associated with a malignancy they're diagnosed with. The age requirement is that the patient is 8 to 40 years of age. We know that 8 years old is pretty young, and it was based on when they can experience puberty and when the actual procedure may possibly be able to be performed. So we know that's a young age, and there's a lot of discussion on the Medicaid side about choosing that age range. The next is, has the patient been diagnosed by a qualified healthcare professional as a requiring treatment that may cause a substantial risk of sterility or iatrogenic infertility? Is the patient's current state of health sufficient to undergo fertility preservation procedures? Has the patient received infertility counseling as well as psychotherapy when medically indicated? And are the methods used in collection and storage of embryos, eggs, or sperm consistent with established medical practices or professional guidelines published by ASRM or ASCO? And again, these are the specific criterion that we have in our manual. So this is generally what was approved by those waivers. For reauthorization, the only one we allow reauthorization for obviously is in vitro fertilization, and we allow up to 3 treatment cycles for IVF for coverage. And so I can show the other 2 prior auths really quick because we have added the same criteria on. So here's the GnRH antagonists. Down here at the bottom, we have added that the patient's receiving therapy as part of in vitro fertilization or as fertility preservation. And then these 2 sections are the same as the 2 sections that were in the previous prior auth and have the same exact criteria for each section and same reauthorization criteria as well for the IVF and no reauth for fertility preservation. And then I'll just show this one as well. This is the same thing as well for chorionic gonadotropin. We've added these 2 criteria down here for diagnosis or reasons for treatment. And then the 2 sections below, again, same criteria, again, for IVF or fertility preservation for those same reasons and same reauthorization criteria. And thank you for the recommendation I just saw in the chat. Any questions or comments on it?
Dr. Sigrid, you got your hand up.
This is unrelated to promoting fertility, but on the GNRH, under the criteria for approval, you have listed paraphilia, and it should technically be paraphilic disorders. There was a systematic review just published in March. There's low quality evidence, but it covered not just paraphilia itself, but paraphilic disorders is how they referred to it. And it's in line more with DSM-5 criteria as well.
Okay, thank you for that recommendation.
Let's see, Jordan, you had a hand up.
This is just more of a formatting thing, but the chorionic gonadotropin under the additional criteria number 2, there's actually not a yes and no box there. And maybe just on mine. Okay, now there is. Just kidding. On yours there is, not mine. Okay.
Okay, it might have been updated since it was last sent out, but thank you for that.
All right. Catherine?
I was wondering if you could elaborate on why no reauthorization for fertility preservation?
Because after they receive the treatment for the diagnosis, they will not be fertile and will not be able to receive that service again, is my understanding.
Okay, yeah, that makes sense. I guess my question is, what if the first attempt at fertility preservation is not successful?
Maybe someone who is more knowledgeable in this part of reproductive health that could give a more specific answer. That was determined by our medical policy team, and we're matching their policy. But my understanding is that it's a procedure that is performed once to collect embryos, eggs, or sperm before the procedures or treatments.
That's a really good question. Right now, I think we are just covering it one time. Medicaid will not cover it for a second time. That can always go through an appeals process if there's a special circumstance. But right now, the policy is just that they get one-time coverage.
Okay, thanks.
Thank you both.
All right. Thank you for the clarification and the questions. Any additional thoughts? All right. Do we have a motion? How about I move to approve?
Second.
Okay, Dr. Britton, thanks for the save. All right, guys. All in favor? Aye.
Aye.
Any opposed? All right. That is it. 8:10, keeping things right on time and finishing early. Thank you, everyone, for your attendance today. Looks like in the next meeting, we're going to talk about antipsychotic use in adults. Do I have a motion to adjourn?
So moved.
Thanks, Catherine.
Second.
Goodbye, everybody. Have a good day.
Bye.
Bye.
Thanks.
Bye.
Stay safe, stay cool.